Good morning, everybody. Today I will be discussing downstaging of hepatocellular carcinoma before liver transplantation. So I will go through the background, then when to downstage, methods, outcomes of downstaging, then downstaging in the scenario of living donor liver transplantation, the upcoming data about downstaging in the presence of portal vein tumor thrombus, then systemic therapy or immune checkpoint inhibitors, and conclusions. So this is one of the first paper discussing almost 40 years back about role of liver transplantation in cancer therapy by the father of liver transplantation, Thomas Darsel, and a lot changed over the last 4 decades. So initially, in the initial era or in the 20th century, the initial results of liver transplantation in patients with HCC were really disappointing and associated with high recurrence rate observed in the surviving patient. But at the same time, the surgeons observed that virtually zero recurrence rate was observed in patients who have incidentally detected small tumors on the explant histopathology. Henry Bismuth from France was the first to report that patients transplanted for HCC with up to 3 nodules and each less than 3 centimeter exhibited the best results. But this most landmark publication from Mazzaffaro et al. From Italy, which reported very good outcomes from a select patient who were transplanted for HCC and subsequently reported as the Milan criteria. And till date, almost after 30 years from this publication, Milan criteria has remained the gold standard not only for selection, but to compare other criteria which were subsequently developed. And it is important that most of the downstaging protocols aim at the downstaging should be to Milan criteria. And these criteria are considered faced criticism despite of the best results, that it is not very flexible, and there is a restriction because it's many centers observed that transplantation even outside, but not much outside Milan criteria, gives equal results. And most importantly, it is only tumor burden based criteria. The biological behavior of HCC is not included. So I'm just, the table shows how the criteria got evolved, and some of them are based on the explant pathology and some of them are based on preoperative imaging, and almost 5-year survival on explant pathology reached up to 94%. So this is summary of the various criteria and studies which have shown the success of Milan criteria. Then after that, most of the prominent centers in the world have come up with their own criteria and showed almost equal results. One of them is most important is Tokyo, where tumor size they kept less than 5 centimeter, but numbers they increased to 5. Then the Hangzhou criteria, Asan criteria from Korea. Then up to 7 is the metro ticket approach. Again, Mazzaffaro himself proposed it. Then total tumor volume and AFP, the first criteria which integrated biological behavior along with the tumor burden. Then the Kyoto criteria. Toronto criteria is one to be mentioned, that it doesn't take in account the tumor burden per se, but they heavily rely that the patient should be asymptomatic for HCC. They do a protocol biopsy of the tumor, and if the tumor is poorly differentiated, they don't transplant. But if the differentiation is good and histopathology is favorable, they go ahead with transplant and have shown almost 72% 5-year survival rate in their model. Then in a consensus international conference way back 15 years back, downstaging was defined, you can say, in patients with HCC, initially exceeding conventional LT criteria, whatever the center adopts, can be downstaging is defined as a reduction in tumor burden using loco-regional therapy to meet acceptable LT criteria. But the condition is that liver transplantation after successful downstaging should achieve a 5-year survival rate comparable to that of patients with HCC, initially meeting the conventional criteria and not requiring tumor downstaging. And based on that, further studies, and this is the reference point where downstaging is looked up to. So there are many key issues when we are discussing downstaging. First is up to outside, how much we should go outside to downstage a tumor. And those are the initial criteria, whom we should select and what is the upper limit that we should restrict, that even after that we will not even consider for downstaging. Then there are many criteria like UNOS, which have adopted in 2017, then UCSF, then Bulgana, and based on number and size, there is the XXL study, which is a RCT, and they have again number, size, and AFP. The key question remains whether a macrovascular invasion or a portal vein tumor thrombus or a hepatic vein tumor thrombus should be considered even for downstaging or disregarded for transplant. And then again in tumor thrombosis, it is whether the early thrombus, which is restricted to the liver, or we should go and consider when PVTT 3 and 4. I will elaborate in detail. And most important is whether accessibility of LT. When you are pushing the criteria for LT in a deceased donor organ transplantation, you are because it's a common organ pool, someone else without HCC may have to compromise about the graft. And when it is a LDLT scenario like in India, it is always comes the concept of double equipoise when you are subjecting a living donor to a definite risk of life, and whether the HCC or the patient, though it is not an emergency, whether have the meaningful survival outcome justifying a live liver donation. Then once we decided we have to downstage, what to do further? So there are many things coming, like TACE is the most established and commonly reported conventional versus the bead methods. Then TARE has shown a better outcomes. Then comes to RFA, then hepatic arterial infusion chemotherapy, and even resection. Some centers have considered as a downstaging thing. And then comes the systemic approach. The hepatologist can tell better. Comes the tyrosine kinase inhibitors, anti-VEGF, and the immune checkpoint inhibitors. And now the question comes whether it is applicable in downstaging before LT, because the fear of graft dysfunction or allograft rejection after liver transplant, then the cost, then the decompensation of ICI, which may have dropouts. Again comes, we have downstage. Then what are the endpoints of downstaging? Whether we should really come down to Milan criteria, or we should be happy that the tumor has remained stable, have shown a complete or partial response, and once downstage, when to transplant. In LDLT, it is easier that you can time the event, but DDLT, it may be tricky, because if you downstage and shortly transplant, then we may miss out on an aggressive biological tumor, which subsequently may show early recurrence after transplant. And if we keep on waiting for a long time, then the tumor might progress despite of a successful downstaging. So these are the key issues. I will go through and show some data, because it's an extensive topic. So this is one of the most, you can say, recent or widely applicable and adopted in United Nations organ sharing in 2017. And it is the inclusion criteria, if we say it is just another number, exceeding UNOS 2 criteria. Single lesion less than 8 centimeter, Milan tells about 5, 2 to 3 lesion, each 5 centimeter, Milan is like 3 centimeter, and all less than 3 centimeter. Then again, the maximal tumoral diameter should be 8 centimeter, or 4 to 5 lesions, all less than 3 centimeter, with some of the maximal tumoral diameter to less than 8. Again, this protocol has underscored the absence of vascular invasion or extrahepatic disease, including lymph nodes, based on the cross-sectional imaging. Then they have only considered child A, B, B8, and bilirubin maximum up to 4. This is the standard downstaging protocol. Beyond that, what they have labeled it as all comers, but it is really not the all comers, and except there is no restriction on the tumor burden in terms of tumor diameter or tumor size, but again the absence of vascular invasion or extrahepatic disease remains there, and you can't take a child C cirrhotic or a bilirubin more than 5. So again, this is all this downstaging protocols, pre-downstaging and post-downstagings are heavily, we are totally dependent on the radiologist and the hepatologist, because the reporting of initial tumor, whether it was in the criteria, and more importantly, which is more difficult and demanding, is the response to treatment. There are M-resist and then are locoregional therapy. Lyrides are available for this. And what they have criteria for successful downstaging, the tumor should come down to within Milan. Ideally, there should be complete tumor necrosis. Only viable tumors are considered. Tumor diameter measurement should not include. This is a bit tricky situation. For example, you have taken a single solitary lesion, which is 6 centimeter. You have done TACE. Now the subsequent imaging shows 2 areas, 2 centimeter and 1 centimeter within that lesion which are viable. So we can't call it as Milan, rather than it is indication for subsequent locoregional therapy, and after complete necrosis, then you can consider within Milan. So only viable tumors are considered. If there is more than one area, what I have explained, and the criteria of the progression is that it is not meeting the Milan evidence of extrahepatic, lymphatic, or vascular tumor spread. And here comes again AFP. Most of the centers are skeptical to offer downstaging if the AFP is more than 1,000, or there is doubling of AFP, but ideally they feel that the AFP of after downstaging should come down to 100. Similar is as I explained in the all-comer criteria, because here we have to be more skeptical on progression of tumor burden beyond Milan, while they are on after successful downstaging. The development of any new lesion is a progressive disease, any evidence of extrahepatic disease, and again the AFP levels. So after these protocols, what are the methods of locoregional therapy? The most commonly used is the TACE, then RFA, then microwave ablation, then SBRT, then TARE, and hepatic arterial chemotherapy infusion. Each procedure have its own indications, and but the most important is that when arterial infusion therapies are used, then the risk of decompensation has to be considered in every patient. So how they assess is, I have already, this is the recent one. After locoregional therapy, the evaluation of the tumor, whether it is viable, non-viable, and whether to be, it is, so it is lack of residual enhancement or presence of treatment-specific enhancement pattern allows lesion categorization as LRTR non-viable, presence of nodular, mass-like, or thick irregular tissue in the which shows arterial hyperenhancement or washout or enhancement similar to the pre-treatment category is considered viable. Otherwise, if not meeting, they are considered equivocal. So this is one of the RCT, though it is published in gastroenterology long back, and it has included only 24 small size number, but what is important that they have reported that TARE is better when there is we consider for time to progression, in which TARE has shown that 26 months versus conventional TACE 6.8 months. The radiologist may argue because it is conventional TACE and the recent advancement in TACE can show the better results. But if we see, there is only, because why it is important that TARE probably gives a bigger window of opportunity to consider the patient whether he can undergo transplant. But once they are downstage, there is not much difference on survival after transplant. This is another recent study in 2024, which again underscores the benefit of TARE for downstaging before liver transplantation. So when we are coming to outcomes, there are a few important papers of different intention. This is RCT, which was closed prematurely, conducted again by Mazzaffaro. And what they did, they downstaged and then subjected whether to go for transplant and or observe. So 74 patients were enrolled in the study. Median duration of downstaging was 6 months. 29 patients dropped out before randomization. 45 were randomly assigned, 23 to the transplantation group versus 22 to the control group. And they had to do cutoff analysis in the middle. So what they have observed is that the 5-year tumor event-free survival in the transplantation group is 76%, and control group, that if you downstage successfully but don't do transplant, are 18%, which obviously statistically quite significant. Overall survival in downstage group is 77. Sorry, 5-year survival is percent, and control group it is 31%. But the treatment-related deaths, if we observe, are almost similar, and 2 patients of transplantation and 2 patients in the control group each expired. So again, the message what I got from this study, if you successfully downstage, again, make every attempt that the patient can go for transplant. Because even after successful downstaging, if the patient don't go, it affects definitely survival significantly. So this is the, there are multiple papers published about reports on downstaging in patients with HCC beyond conventional criteria. I will just draw your attention to the last column, and if we compare the 2010 consensus, that only 4 studies have reported 5-year survival. And what the expected is that when you are subjecting patient for downstaging before transplant, you should achieve a 50% minimum cutoff, 50 to 60% 5-year survival. But most of the studies have restricted their survivals at 3 years, 2 at the 4 years, and 4 at 5 years. So again, this is another recent paper I will like to quote here. Downstaging of HCC before liver transplantation. This is a multi-center study from USA, and they have a consortium of Merits LT, and this is where they have considered all-comers protocol in the study. So, So what they have observed, other outside the UNOS criteria, and when they are considering the all-comers patient compared to those meeting UNOS criteria, that they have 82 all-comers and 229 within criteria patients. They have 67% probability, all-comers have 67% probability of successful downstaging, but the 3-year survival in all-comers was nearly 60%. Here also they have not reported 5-year survival. Though AC with child score BC and AFP more than 500 have poor survival. Explant pathology showing complete tumor necrosis have a better outcome than residual tumors. This is another study recently published in Hepatology, Downstaging of Hepatocellular Carcinoma before liver transplantation, the results from a national multicenter prospective study. 396 patients meeting UNOS DS criteria, 190 were all-comer criteria, 9 liver transplant centers were involved. The study was conducted over a period of 8 years. They have pre-transplant, they have similar AFP levels, MED score, and child status. 2 years after the first liver locoregional therapy, 82% of the patient within criteria and 66 of patients in all-comers group could be successfully downstaged. There is a difference. In all-comers, the downstaging rate were 72% for tumor number plus diameter, largest less than 10, 51% when the sum is 10 to 12, and again 39% for more than 12. So again, there is some number-based criteria coming here also. Then TARE achieved a higher downstaging success than TACE, 74% versus 65%, 48% of within criteria and 40% of all comers underwent liver transplantation. So the chance of getting liver transplantation is almost similar. And if we compare the 5-year post-transplant survival was similar between criteria, UNOS criteria, and the all comers criteria. So this is most important because 5-year survival they have. Yeah, but it is associated that 5-year post-LT recurrence rate was higher in all comers compared to the within criteria patients. So coming to the living donor liver transplantation, again I have an American paper published in 2024 annals. So they have a wider range of 99 to 20 years with a multiple center cohort of 12 centers and 360 LDLTs performed during this this period, and they have what is this NYCA, New York Cancer score have come, and that they have shown has some significance. So what they have observed, post LDLT survival within Milan and outside Milan was similar. Within UCSF versus outside UCSF was similar. Then the post LDLT recurrence-free survival also they didn't found a significant difference. But what they have again come to is this cumulative incidence of recurrence. It based on the NYCA score. Higher the score, the recurrence rates are more. So coming to the most present scenario, whether to downstage a patient with PVTT and HCC. So this is a reference diagram showing the 4 grades of portal venous tumor involvement. VP1 presence of thrombus distal to second order branches or segmental branches. VP2 is the sectoral branches. Then the VP3 is the lobar branch, first order, left and right portal vein, and VP4 thrombus in the main trunk of portal vein. So again, there are many studies who have reported outcome of liver transplantation. I have just divided them, the studies published in the previous studies. And again, there is, here we see when it is approaching, if we again just score at the last column, they are just approaching 50%. Some of them have survival of less than 50%, then some have just crossed 50%, but definitely it is not what expected from the conventional criteria. So these are the recent studies, again from predominantly from the Asian countries, again showing the similar results. So to summarize this, I have taken this from a review article where there was published in Hepatology, JOH, sorry. What is the current scenario about, and it is a commentary. So in general, at present, liver transplantation is contraindicated in the presence of portal vein tumor thrombus. Downstaging approaches may justify liver transplantation, but that has to be individualized from the center depending on their activity, like whether DDLT, LDLT, and what facilities for downstaging are available with them. Currently, it's too early to include liver transplantation for portal vein tumor thrombus in any consensus guideline because there is no high quality data. Type 1 portal vein tumor thrombus may have a favorable biomarker profile. LT offers better survival than palliative approaches, but definitely in future data available, which type of PVTT, 1, 2 versus 3, 4, and which successful downstaging approaches may facilitate successful transplant will be clear. So coming to the systemic therapy, which is the recent addition in the HCC treatment. So at present, there are so many ongoing trials about systemic therapy in the perioperative setting in liver transplantation. Most of them are either United States or China, and one from Italy. So this is the important study with some different intention, that intention to treat outcomes of patients with HCC receiving immunotherapy before liver transplant, the vitality study. So this is the graphical abstract, and this is the study design, whether they have. So what important is that what is the concern from transplant point of view, when to transplant this patient, or there is any additional risk to the liver graft for the patients who have received immune therapy of this. So coming to that, in this cohort, 86 patients exceeded Milan criteria. 65 of them were successfully downstaged within a median of 5.6 months. 43 of them underwent transplantation. 18 were initially within Milan and 23 downstage. This is difficult for me to understand why a patient who was upfront receiving within Milan was given immune therapy. It might be probably because the wait time was longer, but again you have to wait for the immune therapy to act and the 2 cycles or 2 half-lives of the agents to clear. Then 94% of the cohort received concurrent immune checkpoint inhibitors and locoregional therapy. There was no grade 4, 5 adverse events occurred on the waiting list. The 3-year cumulative dropout was 28% for those within Milan and 48% outside. Independent predictors of dropout was obviously beyond Milan criteria, then AFP doubling from baseline, and radiologically poor response. The 3-year intention to treat survival rate was 71%, 73% within Milan versus 69% beyond Milan. Not much difference. 3-year post-LT survival was 85%. What is most important is the last 2 lines. Only 7 patients experienced rejection after immune therapy, after transplant when they received immune therapy. And they have reported 1 graft loss. And what they underscored that out of the 7, 6 patients received their last dose of ICI less than 3 months prior to liver transplant. This translates to our understanding that the waiting period should be 3 months so that the 2 half-lives of the agents are taken care. So this is another complex algorithm and really needs a multimodality approach and has been published in Hepatology. I have taken it from the review article. But personally, I feel that this is based on purely a DDLT program when there is a definite wait list and they have to establish criteria, but some of them can be utilized in LDLT and an individualized approach can be followed. Coming to the ILBS experience, this is a paper published in 2021 in Indian Journal of Gastroenterology. How does it differ? It's really important because what till now I have narrated is from the ideal scenarios or Western scenarios, and what exactly how the Indian patients present is interesting to know. So by then 600 transplants were performed, and out of them 53 were HCC, 40 had a preoperative diagnosis, 13 had incidental. And the median MELD score was 18. The important is that HCC as the primary indication for transplant was just 20%, and they followed, we have here the up to 7 criteria when the largest tumor diameter and the number of nodules, the sum of them should be less than 7, and outside up to 7 criteria were 21, and this was the treatment algorithm which was followed in ILBS, HCC with cirrhosis, no major vascular invasion or extrahepatic disease. Still we stick to that with a good performance status, portal hypertension up to 7 criteria, AFP less than 400, PUCA2 less than 200, and no vascular invasion. We straight away go for transplant. Beyond up to 7 criteria or minor vascular invasion, initial AFP more than 400, PUCA2 more than 200, or logistic issues, then the loco-regional therapy either in the form of SBRT or SBRT re-evaluation at 6 weeks to 3 months and transplant if there is no progression. So overall 5-year survival reported was 85% and recurrence-free survival was 83% after a median follow-up of 35 months. This was similar to LDLT for other indications in the cohort. And what we have found in logistic regression analysis that the retreat score, which is based on the AFP and the viability of tumor on the explant pathology and presence of microvascular invasion, predicts the best is the best. Retreat score was the best able to predict recurrence. The patients with HCC in India present late for liver transplantation because 80% of patients had to transplant for decompensated liver disease. Most patients have some form of decompensation before they undergo LT. In this cohort, almost 50% patients have preoperative loco-regional therapy. Another interesting paper I found from ILBS is the outcomes of radiotherapy in multimodality treatment of HCC with portal vein tumor thrombus. So this is a retrospective study, 24 patients without extrahepatic disease, 10 patients have TACE prior to the radiation therapy. Systemic treatment received in 14 patients before radiotherapy. The dose was 12 to 31.5 gray, 3 to 7 fractions of 4 to 5 gray to PVTT or PVTT plus liver parenchymal tumor. All patients were advised to receive systemic treatment with either sorafenib, lenvatinib or nivolumab after RT. After RT, patients had received DEP test again within 8 weeks. So the disease control rate in PVTT was 50% at 3 months. The median overall survival reported is 10.9 months. The 6 months, 1 year, 2 year, 3 year survival rates overall were 75, 45, 25, and 12.5 respectively. Probably this is the 6 months time. This is important for downstaging purpose. If we and more aggressive treatment to for downstaging should be attempted. The median survival was 30.4 months versus 18.1 months with complete or partial response. Another indicator. One patient underwent LDLT, that is quite interesting and encouraging, and complete necrosis with no viable tumor was observed in the explant. So coming to conclusion, definitely downstaging of HCC before liver transplantation is established. Downstaging needs to be protocol-based and based suitable for the center with multimodality approach. And the PVTT, what I can say is the careful selection of the patient is the key. And in future, systemic therapy will be integrated with more clarity in the algorithm.